Okay, well, welcome everyone. I am Ann Greiner and I am President and CEO of the Primary Care Collaborative, and we're delighted to welcome you to the PCC's first ever journal club. I think we've got a really exciting hour in front of us. For those of you who may not know the Primary Care Collaborative, we are a 13-year-old nonprofit, nonpartisan membership organization of many different sectors in healthcare who have varied roles and interests, but they share this common commitment to strengthening primary care as a foundation of a high-value health system. And we have found over the course of our 10 plus years in existence that we get further faster when we all come together and advocate on behalf of primary care. So we're excited to have you here today. And let me begin by introducing the co-chairs of the of the Journal Club, and then we will get right into the meat of the meeting. First, let me introduce Irene Mullins, who's both a physician and has her master's in public health. She's Chief Health Equity Officer and Deputy Chief Health Officer at IBM Watson Health. And Irene is a physician researcher with 2 decades of experience in clinical research, public health, disparities, and population health. And she's also spent a decade delivering and managing frontline primary care, preventive services, and community-based clinical research as a public health physician and medical director. So Irene has worn many hats over the years, and I think brings a real depth to the conversation we're going to have today. Prior to IBM, she was a medical officer at the National Institute of Health, where she had a number of different roles. Most recently, she was Deputy Director for the Division of Scientific Programs within the National Institute of Minority Health and Health Disparities. She also was awarded the first NIH Director's Award for exceptional contribution to advancing science of health disparities. Our other co-chair is Jack Westfall, and he's also a physician and has a master's in public health. And he's director of the Robert Graham Center and a family doctor in Washington, D.C. Jack was on the faculty of the University of Colorado for over 20 years, and he had a number of interesting roles during those 2 decades, including Associate Dean for Rural Health, Director of Community Engagement for the Colorado Clinical Translational Science Institute, AHEC Director and Senior Scholar at the Farley Health Policy Center. So you can see our co-chairs really have such varied experiences. Before he joined the Graham Center, Jack was a medical director for whole person care and health communities at the Santa Clara County Health Hospital and Public Health Department. Before we dive into the program, I just wanted to provide a little context of why we are doing a journal club. We've come to the conclusion, and I think for those of you who are joining us today, you may share in this sentiment, that we need to better disseminate primary care research, both health services research and clinical research, to decision makers, both those we consider big P decision makers, policy makers, you know, in the federal and legislative branches, both, and also folks at the state level. So if you're in a regulatory role or a legislative role, and small p policymakers, individuals that can influence the care delivery of lots of primary care clinicians. So we're interested in better getting information to these kinds of decision makers. And this project that we are embarking upon, which is funded by PCORI, is setting out to do this in a number of ways. Stay tuned for a curated list of the, of very important seminal articles from primary care. We're going to come up with a list of about 25 articles that will be disseminated in many ways through this journal club, but also on our website, through treatment in different ways, through varying publications, and potentially through other media as well. So we're really testing ways to better get this important primary care work, sorry for my phone, into the hands of decision makers. Without further ado, let me now turn the baton over to Jack.
Great, Anne, thank you very much. Welcome to everyone to this journal club. Bridging the gap in primary care research is crucial. There's a lot we know, but it doesn't get to the right people. It doesn't either get to the patients or the practices, or in this case, really to the big P and small p policymakers who are making decisions around how primary care fits into their community and their health systems every day. And so I was very excited when Anne asked me to participate in this. I was very excited. It's been great to get to know the co-facilitators and today's speakers, particularly whom I have admired for for a number of years. As a family doctor and a primary care physician, I want to also make sure that we help everyone understand that we are thinking beyond just physicians in this primary care research gap. We think of primary care writ large. What are the components of primary care and how do we get those into the right policymakers' hands? So I get to introduce and facilitate a conversation with Dr. Sanjay Basu, MD, PhD. He is a primary care physician and epidemiologist. He's the director of research at the Harvard Medical School Center for Primary Care, as well as the vice president of research and population health at Collective Health. He has over, from an academic standpoint, he has over 300 peer-reviewed articles and has been named one of the top 100 global thinkers. Let me just suffice it to say that his bona fides include he is a practicing primary care clinician. He gets into the clinic and sees people. He has worked in administration and he has done research and published a significant amount of work. It's really exciting to have him here present our first article on the association of primary care physician supply with population mortality in the United States between 2005 and 2015. Dr. Basu, thank you for joining us today, and I'll turn this over to you for a brief presentation of your paper, and then we'll have some Q&A from the audience and some special questions from the facilitators as well.
Thanks, I appreciate it. Thanks for the invite. Nice to see so many of you, at least virtually. See many friends around the gallery view room, the Brady Bunch here. If we go to the next slide, it'd be hard to discuss PCP and population health relationships without acknowledging the dramatic work of Barbara Starfield and colleagues who have provided a rich literature on this topic. I'm just sampling a couple pieces here from a broad repertoire. Starfield and colleagues certainly highlighted relationships between primary care and mortality or life expectancy for many years. Here's one figure from just one of their publications at the state level, but naturally faced some criticism around, well, lots of things travel together with primary care density or availability, and lots of things travel together with life expectancy. So if we are saying that we should invest more in primary care availability, how do we know that this is a relationship that's not driven by a number of other things? So on the next slide, talk a little bit through some of the challenges that we have since the publication of the Starfield report. On the left, primary care density changes. On the right, specialty physician density changes based on the AMA master file data. One sees quite a loss, at least at a geographical level. You're looking at census tracts of primary care and largely neutral or gain, though not everywhere, in specialist density. On the next slide, how might we piece together some understanding around primary care availability and either mortality or life expectancy. A lot of harmful things travel together: poverty, lack of education, numerous social determinants of health, and a lack of primary care access. One, of course, also has differences. Every PCP is not the same. There's differences in insurance quality, infrastructure, hospitals, health plans. And of course, at an area level, we could commit ecological fallacies by doing regressions on an area level and applying it to individuals. We could also commit individualistic fallacies, which is the concept of taking only individual level analyses, trying to apply it to broad groups or populations or whole geographies. And so we have to be careful of both. Here's the approach we took. On the next slide, we did several different approaches. One approach is saying, okay, first of all, we know that areas are different. We have lots of choices in defining geographic areas. So let's do the analysis at multiple different areas, not just counties, census tracts, or hospital referral regions, but a variety of them to see if there's any consistency depending on when we change the geographic area of interest. And let's also account for a few different things. One is the starting points could be different between areas, where they are in a baseline life expectancy over time. The slopes could be different. Some areas could benefit much more from each additional PCP than other areas which may be very saturated, for instance. There could be differences in time trends or overall grouped time trends. As I showed you on that map, overall reductions in PCP density. And of course, there could be unmeasured differences. I sit in the Bay Area today. There's something about Berkeley that's just different from other places, the Berkeley factor. And what is that? Is it simply demography? Is it health plan factors that people wake up in Berkeley and fall into a pile of kale? That's not measured in any common surveys. And so we include so-called fixed effects, these unmeasured differences that might be something about a place of je ne sais quoi that we might have to account for. So that was one approach we took. A second approach on the next slide is so-called instrumental variable analysis. I like the analogy that was given years ago by some colleagues who were studying smoking. And when they went up against what is now Altria, Philip Morris at the time, Philip Morris argued, well, you know, people who have cancer are depressed and cigarettes improve depression. So maybe cancer is actually causing increased smoking rates in your data set, a reverse causal relationship, or there's other unmeasured factors. And they looked at cigarette taxes and said, well, no one's increasing taxes due to cancer rates. So the association between cigarette taxes and mortality is probably unidirectional and suggesting that it's actually the cigarettes causing cancer, not cancer causing cigarettes. Reverse causality is important to acknowledge. And in our case, instrumental variables is some variable that helps influence how much somebody has exposure to a factor, in this case, primary care, and how that relates to the outcome, in this case, mortality or life expectancy. We found that particular loan forgiveness programs, the value of that program was not chosen by local life expectancy or mortality rates. In fact, was rather a strong predictor of primary care rates, and so could be used as a way of instrumenting the primary care availability. Turned out not to be very predictive of specialist availability. A couple other approaches we used in the next slide. We looked at individual level data. We had some claims data. We looked at the individual exposures that people had to availability of primary care and their associated mortality accounting for censoring. And in particular, looked at people who moved between zip codes. They were exposed, otherwise similar people, but one moved, one didn't. How did their change in exposure to primary care relate to their change in subsequent mortality? Which kind of mortality? And we also did some falsification testing. Is it just that primary care providers are attracted to nice places? If so, then non-amenable causes of mortality like murder would be associated with primary care. We wouldn't expect primary care availability to reduce murder rates. And so this kind of falsification testing is important to look for false correlations that we haven't controlled for. Finally, let's say we forgot about everything and these approaches are just not good enough. How much might an unmeasured confounder, something else associated with primary care and life expectancy that we couldn't measure in our data sets, how big of a factor would need to be there to explain away the association and make it a false correlation? So here's what we found on the next slide. Overall, when choosing between different area levels of interest, and we did several of these, but here are 3: county, primary care service area, hospital referral region. Still had some associations between increased primary care availability and improvements in life expectancy, actually with larger effects when we went to larger areas, accounting for people's mobility. When we weighted by geography, how distant were you from primary care? When we did the instrumental variable analysis, and we actually have devised and applied a new method called near-far analysis, which makes an instrument stronger. It compares two people who are otherwise similar in all their characteristics, but one faces the instrument, one doesn't. So people in a county where the loan forgiveness program was operating more strongly than another, but they're otherwise similar, you'd see the loan program and associated primary care density improve mortality, and in their individual level analysis, not just at the area level. Going on to the next slide, you'll see a bit about where we compare to specialists and also which causes the mortality. Those that are mostly amenable to common treatments, such as blood pressure, heart failure treatment, cancer screening, COPD, asthma medications were those where we saw the biggest impact from primary care. Also sizable impacts from associated specialists, less impact on some other factors like substance use or injury. We did not find an association with murder or other interpersonal violence as a falsification test. And if you go to the next slide, we also found that when you did this instrumental variable or when you did near-far methods, really had very consistent findings by cause of death. What's interesting is, suppose we didn't do enough different approaches here and there's still an unmeasured confounder after all of our control variables, demography, health plans, hospitals, whatever else we included. You'd have to have another unmeasured confounder that was associated with both primary care density and life expectancy about the same effect size as poverty in order to explain away this association. It's a pretty large unmeasured confounder to not be able to account for. So on the next slide, a bit about what I think would be nice for discussion, policy steps. I think the big elephant in the room is how does one increase primary care density? We did some secondary analyses on there, payment reforms, particularly those favoring so-called cognitive professions, and whole person care seem to have early signal for improving primary care density, shift to capitated and value-based payments. We have a lot of new whole person care financing going on, including those that don't just pay for utilization, but really pay for wraparound services and a more of a chronic care model. And of course, there are several pieces of legislation that haven't yet had either passage or haven't yet taken full effect. The primary care for you legislation in Massachusetts still being drafted to shift towards capitation. We've done some early studies around Rhode Island, Maryland, Delaware, where we start to see increased investments in primary care, making some impact on the supply side, but we're waiting to see on the outcome side, cost side, what happens. And of course, the med ed focus here in terms of upstream efforts, we still often find medical schools graduating smaller and smaller portions of primary care providers. So I'll leave it here. Thank you so much for the invitation and turn it over for discussion.
Oh my gosh, thank you very much. I think the description of your methods was very helpful, and I really appreciate that in-depth look at the methods to build the credibility behind this. And I think that's really crucial as we go through these journal clubs to think about, you know, what is the credibility of this for people who are potentially making policy? Because as you have said, this isn't necessarily primary care to the individual. This is related to a bigger policy. And you want to make sure that the evidence supports that. So thank you very much. I'll start. We'll see what the audience has for questions. Please put those questions in the chat. And I'm going to ask one to get us started and just ask, what's your belief or opinion on the process by which primary care impacts mortality? You've talked a little bit about some of the possibilities, but what's your, both from this paper, but also your understanding of what primary care does that actually results in this outcome?
Yeah, there's quite a few papers out, both at the individual and population level, that suggest some key interventions that may be helpful. None of them are surprising, perhaps, but some of the biggest impacts seem to be related to blood pressure treatment. And defining primary care broadly also includes a lot of the pediatric vaccination space, and now also the adult vaccination completion. And interestingly, and we can talk about the complexity of this, in early years of the opiate epidemic, we saw a bad association between primary care and opiate use. In more recent years, we see a more positive impact between primary care and opiate use. Indeed, there's also some interactions between primary care availability and other aspects of the system. Primary care availability having particularly high impact in some of the more rural zones where there's, in other words, each additional primary care provider is making more of an impact than in those zones where there's already saturation. But even in the more saturated markets, we're seeing quite an impact of cancer screening as well.
Thank you. So there's been a couple of questions related to, are there other studies around the world? What's the international experience and the world's experience of primary care, and how does the United States primary care fit into sort of a world literature on primary care?
Sure, and Barbara Starfield and colleagues certainly had a lot of nice international comparisons to make. Unsurprisingly, the investment in primary care relative to GDP or relative to amenable mortality is lower in the United States than in many comparable countries, at least when you compare against OECD countries. But actually, interestingly, even when you expand beyond some high-income countries to look at middle and lower-income countries, that continues to persist. Although it's hard to make broad cross-country comparisons, many authors have, and they found that during periods of increased primary care investment, the United States tends to have more improvement in amenable mortality than in some locations that might have more saturation of primary care workforces. But we also have more diversity, more heterogeneity, rather, I should say, in terms of the availability, such that a lot of the averages for us are disguising a much larger distribution, a much wider distribution than in other locales.
So there's a great question. I worked in a small town, and we saw this frequently with small towns recruiting docs from each other. And so Clarissa Hoover asks, how do we address increasing primary care density in some spots without reducing it elsewhere? I think this gets it with loan repayment. Those were spots that may be taking primary care from other places. So what are your ideas about how do we, and this is another question, how do we increase density? And I think Clarissa Hoover's question is without negative impacts in other places. So,
yeah, hugely important question. When we went back historically and looked at different efforts over the last few decades, we often found this type of perversity where towns stealing from each other per se, and then you saw kind of a flip in the ability to improve some minimal mortality whenever there was flight of a physician to another location. And so it's really important. There's a few different answers I'd have. One is the upstream issue of seeing which medical education and post-education residency and post-residency incentives seem to help improve the rate of primary care specialization among folks going through the pipeline in order to increase the overall amount. That being said, we've also been looking at ways of extending the existing reach and arm of primary care providers so that as they're demanded to have more empanelment, there's so many demands on primary care providers, can they effectively have a larger workforce at the top of their license, mobile pharmacists, mobile community health workers, social workers, and so on, so that we're talking about whole person care, where each person is administering at the top of their license rather than trying to be the end-all be-all provider for all needs. And we're starting to see some positive results from a few of those, but not every type of pilot in that domain.
I think we can't really talk about primary care without talking a little bit about the Affordable Care Act. And there's a question about what are your opinions, or what's the evidence for the impact of the Affordable Care Act on both access to primary care and the outcomes associated with primary care?
Sure. My read of the literature, and there's a lot there, is it depends on which aspects of the ACA we're talking about. Let's say over the life course, starting with people getting increased access to preventive care either during the prenatal or postnatal or pediatric period. There certainly are associations with improvements in maternity outcomes and pediatric outcomes, such as amenable hospitalizations for asthma, increase in vaccination rates. The Medicaid literature is complicated. During the Medicaid expansion, we certainly have evidence of early increases in ER use and some hospitalization use, perhaps related to pent-up demand, and perhaps a more delayed access of primary care, or in one complex relationship between safety net hospitals and non-safety net hospitals. Those under the Medicaid expansion often shifting between providers. And so like really some complexities around Medicaid expansion, but overall relationships with improvements in mortality, amenable mortality, and we certainly see some generational effects now going on in the prenatal period. Among older adults, more in the Medicare space, we see less effects directly from the ACA from what I can read in the literature.
Dr. Basu, thank you. There's a lot of ways to impact the primary care density, and I think HRSA and the loan repayment programs, and there's been ways to try to access or to increase primary care in rural, urban, underserved communities. There's a question about sort of from a payer perspective. What's the payer role in working to increase primary care providers, and how might that work synergistically with sort of federal and state, sort of a public-private work to increase primary care physicians, but particularly what's a payer's role in this?
Yeah, and I see some payers on the conversation, so I'm interested to hear how they feel. But I think there's certainly been over the last several years increased interest in primary care from the payer perspective. I do worry about overselling the short-term cost saving advertisement that somehow investment in primary care will result in short-term cost savings. I think Zuri Song and others have reviewed the literature on this, and it takes much more sustained investment. And it's not necessarily that the zero sum will be a net savings. But nevertheless, we have a long way to go in terms of quality improvement and outcomes improvement that may be achieved. I feel like I see a lot of heterogeneity in the payer space. Although there's interest in primary care, I worry that by payer, it may be diluted by so many other financial incentives. For example, in the Medicare Advantage space, we see a lot of gaming of billing. I'm not sure that it's improving outcomes, but there's entire companies that are basically billing optimizers now for Medicare Advantage, and they know how to play the risk game and be really advantageous with how they do risk and how they bill, how they code rather. Similarly, I do feel like Medicaid is kind of stuck in fee-for-service for a great degree. I'm saying this as somebody who works in FQHC. We're overly utilization focused, really wedded to prospective payments and not moving to value as fast as we can. So getting a push from payers who will invest outside of that and push us towards value, I think would be a good thing. I'll probably be killed by my boss for saying this out loud. But FQHCs, it's like the cool kids table at the cafeteria. They got it all worked out, but we don't really see that in the outcomes. And so I think we have to push them.
So I'm going to take the facilitator's prerogative and ask one last question, and then I'll turn it over to our next half of the Journal Club. So you have a magic wand. I've given it to you, Dr. Basu. You have it. It's a policy wand, and you can create a policy to increase PCP density. What do you do?
I would say flip the pay scale. I would pay for outcomes on a risk-adjusted basis where the risk calculator is invisible to the provider. I was trying to have a pithy answer and then I added a lot of asterisks. Sorry.
I really appreciate that, because I think flipping the pay scale was the answer. And then you noticed the participant list, and your boss probably was texting you about the other question that you just answered. And so you had to think about your answer a little bit more and add some, as you said, asterisks to that. Thank you very much for sharing this paper, Association of Primary Care Physician Supply with Population Mortality in the United States. What a fantastic paper. What a fantastic start to this Journal Club. I'm going to turn it over to Dr. Mark Mullins, who will take it from here. Thank you very much for joining us.
Yes, thank you. I agree. This was fantastic presentation. Great discussion so far. So thank you so much. I am also pleased to introduce our next speaker, Dr. Eugene Rich, who is going to talk about primary care practices, providing a broader range of services, have lower Medicare expenditures, department utilization. Dr. Rich is Senior Fellow in Mathematica's DC office, a general internist, health policy researcher. He has a career-long focus on the influence of policy, payment, and practice environment on health professionals' decision-making, including policies relevant to improving primary medical care. And in addition to his expertise in health services and health policy research, he has deep experience in academic and private practice leadership, including physician hospital organization medical director and medicine department chair at Creighton University. So since joining Mathematica in 2010, Gene has led numerous relevant projects, including directing AHRQ's Coordinating Center for Comparative Health System Performance, which has identified and characterized U.S. integrated delivery system. And for the Alternative Payment Model Program Analysis contract with CMS, he leads the review and analysis of various proposals to reform Medicare payments to clinicians. So we are delighted and thrilled and pleased to have Gene speak with us on our next journal and article. So I will hand it over to you.
Very good. Thank you so much, Dr. Mullins, and really pleased to share this work with this group today. Next slide. So as I think everybody on this call knows very well, comprehensiveness is one of the core key elements of primary care, and it's been defined as the extent to which a patient's primary care provider recognizes and meets the large majority of the patient's physical and common mental health care needs. There are, as my colleague Ann O'Malley wrote in a JGIM article several years ago, there are several aspects to comprehensiveness in primary care. One of these is involvement in patient conditions, which is the depth and breadth of conditions managed by the primary care practitioner. And another related aspect of primary care is new problem management, the extent to which the PCP can effectively address the wide variety of relatively common problems their patients may experience and present to the primary care office. And Dr. O'Malley and our team have developed reliable and valid Medicare claims-based measures of these two dimensions of comprehensiveness. But another aspect of comprehensiveness that's actually been studied for even longer is range of services. Next slide. And we've already invoked Dr. Barbara Starfield's work in our first paper, and I think it's appropriate that we now invoke her work again, recognizing that Starfield, among others, focused on the range of professional services available at the primary care practice site as a way of measuring comprehensiveness of primary care. Now, in our work, we've recognized that involvement in patient conditions and new problem management are features of comprehensiveness that involve diagnosing and managing problems, planning pharmacotherapy and other complex interventions that engage a patient's multiple conditions. And it's conceivable and plausible that these are best understood as individual primary care clinician competencies and measured at that level. But the ability to provide key primary care services might be a primary care practice site characteristic, not necessarily an individual PCP characteristic. Next slide. And indeed, Starfield, who with her team developed a variety of approaches to measuring through surveys and other means, comprehensiveness and other features of primary care, used the approach most typically of measuring the services provided by the primary care practice site. And her surveys included a long list of potential services. Next slide. Now, in our work, and this was conducted initially in support of the Comprehensive Primary Care Initiative evaluation by CMS, in our work, we developed a Medicare claims-based measure of practice range of services to assess the comprehensiveness of services that a primary care practice site's primary care practitioners provide to Medicare beneficiaries during a particular year. And so we identified illustrative services that were relevant to Medicare beneficiaries over 65 that we thought could also be detected through Medicare claims. Now, this means that some services that were in Dr. Starfield's list were not included. For example, we did not look at services related to fertility and reproductive health, since Medicare beneficiaries over 65 rarely have that as a primary feature of their health care. There are also some counseling services that are not typically billed as such through primary care practices. So we selected these 5 categories of services that we thought were relevant to Medicare beneficiaries over 65 and could be detected through Medicare claims: immunizations, counseling for common behavioral and mental health problems, treatment of minor lacerations, cryotherapy and/or skin excisions, and joint or tendon injection. Next slide. So in this work, we reviewed all the Medicare claims billed by each primary care practitioner, and these were primary care physicians, nurse practitioners, or physician's assistants practicing at primary care practice sites as part of the CPC evaluation. And a score of 5 indicated the practice site provided at least one instance of each of the 5 services during the year to at least one of their Medicare beneficiaries seen. A 3 indicated it provided at least one instance of each of 3 categories of services, and 0 meant that the practitioners at that practice site never billed for any of the 5 categories of services during that year. Next slide. Now, as I've already mentioned, the analyses were conducted in the context of the CPC initiative evaluation. So we were observing over 6,000 primary care physicians and advanced practice clinicians in over 1,300 practice sites. We measured practice range of services in 2013 using Medicare Part B claims, and we looked at cost and utilization outcomes for beneficiaries in 2014, so the year after the practice's comprehensiveness was observed. Next slide. And so what did we find? The first thing that we found was that there was indeed substantial variation across practice sites. And of course, many of these practices were actually participating in the CPC Plus initiative. So they were intending to be advanced primary care practices. And nonetheless, there was substantial variation in the degree to which these practices provided these categories of primary care services, with relatively few, as you see on this slide, delivering all 5 categories of services to their Medicare beneficiaries, and 20 practices only delivering, or 20 practices delivering none of these. Next slide. In our multivariate analysis of practice characteristics, we found, embarrassingly, because of course I'm an internal medicine physician, the practice sites with more than half of primary care physicians in internal medicine provided a narrower range of services than those with more than 50% of primary care physicians in family medicine. That larger practice sites with 4 or more primary care physicians provided a broader range of services than smaller practice sites. And interestingly, the practice sites with at least 1 NP or PA were not associated with a broader range of services. Next slide. As the title of our article indicates, practice sites with on the high end, the top quartile of range of services had significantly lower rates of ED visits and significantly lower Medicare spending. There was no association observed between practice range of services and hospitalization rates. Next slide. So in conclusion, as we note in our discussion, we present a reliable and valid claims-based measure of practice site range of services. And we observe that when practices provide a broader range of services, their Medicare beneficiaries subsequently experience fewer ED visits and lower total spending. We make the point that practice range of services can be readily measured using diverse data sources from Medicare claims, as we do here, to electronic health records. And we note that various strategies could help primary care practice sites provide a broader range of those services most needed by their Medicare beneficiaries. And I'm happy, next slide, I'm happy now to take questions.
Great. Thank you so much. Thank you, Jean, for this seminal work. Really insightful. As you were discussing, I'm thinking about, let me just, think about where I go see primary care and the practice. I'm sure the next time I go in, I'll be looking for, the broad range of services that they offer. I'd like to also start with one question to get us started. Your work focused on the range of services provided by primary care practice sites. Do you have any information regarding the range of services provided by individual primary care physicians and whether that was important to patient outcomes? So any information whether the range provided by the individuals instead of practice sites?
Yeah, that's a very good question. Well, of course, we're applying this work now in the context of the Comprehensive Primary Care Plus evaluation, where we have much larger numbers of primary care clinicians and practice sites. And we're in the process of finishing a report and submitting for peer review work that looks at individual primary care physicians relative to practice sites. And so that stay tuned. We hope that we will be able to share that with folks soon. I will note that interestingly, while my colleague Ann O'Malley has published that while involvement in patient conditions and new problem management are important at the practice site level. It is actually more related to the individual primary care clinician. So I think this is a substantive question. Does it matter if the individual primary care clinician personally provides these services or not? So stay tuned.
Right. So were you surprised that practices with nurse practitioners and PAs did not have broader practice scope or broader range of services?
I was surprised. And obviously, since I'm an internist, I relied on my PA and nurse practitioner colleagues to do the procedures in our office that I did not feel comfortable doing. And I figured, well, surely that's what other docs are doing. But we did not find that, at least as direct evidence. Now, of course, the first thing I'll note, and we note this in the paper, is that we can't observe directly the range of services of the nurse practitioners and PAs because of incident to billing in the Medicare program. So there's a financial advantage for practices paid fee for service for the service to be billed under the NPI of the physician at the site rather than the NP or PA. Nonetheless, for most of the NPs and PAs, we did observe some services they billed directly, and the services they billed directly were less likely to be the kind of procedures that the physicians were billing for, which we found interesting. But again, it might make sense that it would be more remunerative for the practice to bill that under the physician's number. Nonetheless, since there is billing going on for those services, you would think that if the PA or the NP were expanding the capabilities of the practice, their presence at the practice would have been a factor. And we were surprised to see that did not happen. We're going to be exploring that further in our continued work. The final point that I will make, which is a tricky one, is that some of these practice sites included primary care physicians, but also specialty physicians. And we cannot know for sure that the NP or the PA was actually there at the site primarily expanding the practice of the primary care physician. They might have been primarily affiliated with a specialist. That's another issue we're trying to explore in our continuing work. So yes, I was surprised, and we think this is an opportunity for further research.
Yes, absolutely. I think there are a couple of questions in the chat. There's one here from the question here about, does the definition adequately capture comprehensiveness? 4 of the 5 elements are minor procedures, the 5th counseling was rarely done. So how do we capture the cognitive services that make up the bulk of comprehensiveness? And what about a term that captures illness burden, mostly in the PC sessions such as multi-morbidity referrals?
Well, it's a great question, and I'll note that that's why our team measures 3 different dimensions of comprehensiveness. So we don't just consider the range of services. We think that the involvement in patient conditions, which gets at the degree to which the physician is managing the breadth and depth of problems the patients have in an active way, and new problem management, the degree to which they can satisfactorily address new problems presented to them without needing referral to specialists. We think that those are getting at some of those cognitive skills. So range of services, and I will admit that, but the way we did range of services is the way Starfield operationalized it as well. It is, if the patient needs a thing that a primary care physician could deliver, does the primary care physician deliver it? So it is a dimension of comprehensiveness, but it is not the only way to think about comprehensiveness, which is why we have these other measures.
Awesome. There is another question. Beyond presence of specialty clinicians, what potential covariates should be explored in future research in this vein? Socioeconomic status, population density. So questions, this is from Larry.
Oh, great question. And in fact, there's a long list of covariates that we have in our paper, and an even longer list and discussion in our appendix. So we've considered, a variety of covariates, including the specialist versus primary care density in the community where the practice is occurring, and the socioeconomic status of the beneficiaries and the relative wealth of the communities, urbanicity versus rurality, et cetera. So we've tried to control for everything we could think of. We are eager for others to point out other things that we should be considering as potential confounders.
Terrific. There's also a question from Anne here. The data on mental health counseling is very disappointing. What is your reaction? Do you expect this has evolved in recent years, and what do you think is the most important policy intervention? And Anne, if you want to add some more, but
well, it was sobering to us, but not shocking. There are a variety of issues around billing the Medicare program for mental health counseling services that I think have made primary care physicians generally uncomfortable using those codes. And I know that was true in my case when I was seeing patients. So it's not just the competency to actually do the counseling, but some hesitancy to use the billing approach. Of course, now there are incentives to also do behavioral health integration, so to have teammates who have those skills. But nonetheless, I'll call out that I know that my colleagues in family medicine have for decades included training in basic mental health counseling and cognitive behavioral therapy as part of family medicine training. So some of this are things that primary care clinicians could do themselves. We are definitely looking at this as part of Comprehensive Primary Care Plus, where behavioral health integration and better addressing of behavioral health concerns is a priority. So stay tuned. There will be more information on what's happening in this space.
we're definitely looking forward to that, and we'll be staying tuned. So one last question, and then I think we're hopefully be on time. Any information on how well PCs are prepared to handle the needs of geriatric patients?
Needs of
Geriatric
patients?
Geriatric patients.
Well, we, in this particular analysis, we did not distinguish those over 65 from the very old. You know, we control for that, but we've not looked at that as, say, an interaction. We do have geriatricians included in the CPC evaluations, but they're in small numbers. I will say, and I think our appendix shows this, the geriatricians have a narrow range of services like the internists on average. So at least, there could be a variety of covariates related to that, including the fact that geriatricians often work in health systems, which often, don't really encourage a broad range of services by the primary care clinicians. So it's sort of hard to know if that's a geriatrics issue or a practice setting issue, but we did not see a broader range of services for geriatricians in our analysis.
Wonderful. Well, thank you so much, Gene, for this terrific presentation and great discussion. And I'll hand it over to Anne.
I want to also thank you Dean and Sanjay for fantastic presentations. I think we all learned a lot, and it's wonderful as well that you're not only researchers, but you think a lot about the policy interventions that might change the facts on the ground so that we can have the kind of primary care that's going to help us address inequities and improve population health. And I also want to thank our fabulous co-chairs, Irene and Jack. They really helped to, I think, ask many fabulous questions, and thank all of you who have joined today. The discussion was really very, very good. I think we've had a successful first journal club, and we want to get more folks in the mix. We have 2 more scheduled for this year. The next will be, so mark your calendars, October 7th, and then the last will be December 8th. You'll certainly be getting notices about those journal clubs. And we would appreciate you filling out the survey that we're going to send immediately after we finish up today, and provide your comments and any ideas about how we can evolve this kind of convening. We're excited to be engaging with some of the most important primary care researchers in the country, and we very much hope that we can engage policymakers in integrating this kind of information into their decisions. We're at the top of the hour, so I will close us out. And again, thank you so much for joining. Fill out that survey and enjoy the rest of your afternoon. Bye now.